Hello, this is the first lecture in a series of lectures on the disorders of respiratory system in pediatric medicine. And before we dive into specific and individual conditions, first, I would like to focus on the common respiratory symptoms. In other words, how do patients present? Patients will not come to you and tell you they have pneumonia or bronchiectasis or cystic fibrosis. Rather, patients come with symptoms, and it is through the characterization and description of these symptoms, in addition to the physical examination and appropriate lab investigation, where accurate diagnosis is made. So first, before we actually discuss some of the respiratory disorders conditions separately and individually, first we will discuss the common respiratory symptoms, including cough, expectoration, hemoptysis, respiratory noises. These are abnormal noises that can be heard either with a stethoscope or without stethoscope, dyspnea or difficulty in breathing, and epistaxis. So we will handle these symptoms individually and probably discuss the etiology or the differential diagnosis of each symptom. Let's begin with cough. Cough is an important defense mechanism of the respiratory system and helps to bring out infected secretions from the trachea and bronchi. Cough should not be suppressed in young children because if there is retention of these secretions in the lungs, it may result in atelectasis and other pulmonary complications. For example, if the secretions are accumulated in the bronchi, it might lead to secondary bacterial infection or even collapse of the bronchi. That's bronchiectasis. Persistent cough can also interfere with sleep, feeding, and even might lead to fatigue in children and may result in vomiting. So the cough reflex is usually controlled by a center within the brain, that is the medulla. We have cough reflex centers in the medulla, and we have the fibers, the afferent fibers that bring information to the medulla, and the efferent fibers that take the output to the effector muscles and the larynx. So this is how it occurs. If there is irritation to the pharynx, larynx, the trachea, the bronchi, and the pleura, there is transmission of the afferent impulses through the vagus nerve and the glossopharyngeal nerves, and these afferent impulses are taken to the cough reflex centers in the medulla, where integration of information and interpretation occurs, and when the output is produced, then the efferent pathways are in the nerve supply to the larynx and the respiratory muscles, where the output can be affected. There are various etiologies of cough, and for the purpose of simplicity, let's group them into two: those that cause acute cough and those that cause chronic cough. Cough is said to be acute if it lasts less than 2 to 3 weeks, and if it is beyond 2 to 3 weeks, then it's regarded as chronic cough. Causes of acute cough include the following: 1. Upper respiratory tract infection caused by mainly viral infection, the rhinoviruses, the influenza virus, the parainfluenza virus, respiratory syncytial virus, adenovirus. Postnasal discharge due to sinusitis secondary to streptococci, Haemophilus influenza, or Moraxella, and this usually occurs in older children. We also have rhinitis, swollen tonsils, hypertrophied tonsils, and adenoids can also cause cough, pharyngitis, laryngitis, and tracheobronchitis. Another cause for acute cough is nasobronchial allergy and asthma. We also have bronchiolitis, pneumonia and pulmonary suppressions caused by Streptococcus pneumoniae, S. aureus, Staphylococcus aureus, Haemophilus influenza, Klebsiella, chlamydia, mycoplasma, gram-negative bacilli, and viral pneumonia, suppurative lung infections. That is, we also have measles that can cause acute cough, and whooping cough and other related syndromes can also cause acute cough. If we have foreign body in the air passage, that can also lead to cough which is sudden in onset. And finally, we have empyema. And what's empyema? If there is accumulation of pus within the pleural cavity, then we can have acute cough. On the other hand, chronic and recurrent cough. Here the etiology they are actually chronic in nature. These are chronic conditions that cause chronic cough. And let's give some examples. We have inflammatory disorders of the airway. And a good example here is asthma. Asthma can cause chronic cough. We have infections, be it viral infection, bacterial infection, chlamydia, mycoplasma, tuberculosis, parasitic infections. They can cause chronic cough. Inhalation of environmental irritants such as tobacco smoke, dust can also lead to chronic cough. Another inflammatory condition here is a syndrome known as Lufla syndrome. And you might be asking, what's Lufla syndrome? Lufla syndrome simply means there is pulmonary eosinophilia in response to body's immune system towards parasitic infection. For example, scariasis, the Ascaris lubricoides, or Strongyloides stachylaris. So usually there is accumulation of eosinophils within the pulmonary system. So those were the inflammatory disorders of the airway: the asthma, infections, inhalation of environmental irritants, and the Lufla syndrome. We have also another group of conditions, the suppurative lung disease, including bronchiectasis. Bronchiectasis, that's collapse of the bronchioles, of the bronchi and the bronchioles. And here what happens is that if there is accumulation of secretions, usually there is dilation of the bronchus, and if there is dilation, eventually there is collapse of the airway. Cystic fibrosis is another suppurative lung disease. Foreign body retained in the bronchi, congenital malformations, and sequestered lobe or bronchomalacia. And finally, immunodeficiency and primary ciliary dyskinesias, where there is problem with clearance of mucus and foreign materials. The third group of conditions, anatomic lesions, tumors, tracheal stenosis, if there is narrowing of the trachea, and if there is a communication between the trachea and the esophagus, the tracheoesophageal fistula, especially the H-type, can also present with chronic and recurrent cough. Miscellaneous causes of chronic cough include psychogenic, habit cough, postnasal discharge, sinusitis, gastroesophageal reflux disease, and interstitial lung disease. The other symptom is expectoration. Young children are not able to expectorate and usually swallow the respiratory secretions. Older children with chronic respiratory problems may be able to bring out the expectoration. Common causes of expectorations include bronchiectasis due to various causes. What are the causes of bronchiectasis? It can range from recurrent episodes of respiratory infection, aspiration of foreign body, congenital disorders like bronchomalacia, cystic fibrosis, immunodeficiency syndromes, etc. So, regardless of the cause, expectoration is a clinical manifestation of bronchiectasis. Lung abscess can also present with expectoration, bronchitis, asthma, and tuberculosis. The amount and nature of the expectoration may give a clue about the cause of the respiratory disease. For example, in bronchiectasis, in addition to the cough, it presents with cough. In addition to the cough, there is usually copious mucopurulent expectoration. So we are saying the amount and nature of expectoration may give a clue about the cause of the respiratory disease. Investigations such as cell count, gram stain and culture, or stain for acid-fast bacilli and culture might help in the diagnosis and guide for treatment. Hemoptysis is another symptom patients usually present with. If you see blood in sputum, what are the things that comes into your mind? What are the differential diagnoses of hemoptysis, in other words? Causes of hemoptysis in children include necrotizing pneumonia, foreign body aspiration, bleeding diathesis, tuberculosis that presents with cavitations, idiopathic pulmonary hemosiderosis, mitral stenosis, dilated cardiomyopathy, and Goodpasture syndrome. Respiratory noises is another common presentation, and when you are listening to abnormal respiratory noises, the intensity and the pitch of the respiratory sounds are very important, because the production, the intensity and the pitch of the respiratory sounds depends on their site of origin within the respiratory tract. The pitch of the sound keeps increasing and the intensity keeps decreasing with decreasing size of the respiratory tract. What we are trying to say here is that as the size of the lumen of the respiratory tract is decreasing in size, the pitch of the sound keeps increasing and the intensity keeps decreasing. For example, snoring is a highly intense but low-pitched sound because it results from the oropharynx. Wheeze is a high-pitched, less intense sound originating from the lower airway obstruction. These abnormal sounds can be produced in the inspiratory phase or expiratory phase, or sometimes in both phases. So let's divide the airway into three. We have the extrathoracic airway, we have the intrathoracic, and the distal airway. As a rule, extrathoracic airway obstruction produces inspiratory sounds. Intrathoracic airway, major airway obstruction, produces inspiratory as well as expiratory sounds, while distal airway obstruction predominantly produce expiratory sounds. Examples of abnormal respiratory sounds include rattling, wheezing, and stridor. Rattling is due to excessive secretions in the pharynx or the tracheobronchial tree during breathing. It's present in asthma, bronchitis, tracheobronchial stenosis. Inhalation of GI contents into the tracheobronchial tree can also result in rattling. Some normal infants may have transient rattling, but if it is prolonged, rattling is pathological. Wheezing is another abnormal sound. It refers to high-pitched whistling sound, audible without auscultation. If it is audible with auscultation, it's called rhonchi. Partial obstruction of the bronchi and the bronchioles produces wheezing. Sufficient air must follow through the narrow air to produce wheezing sound. This may be due to causes within the lumen or in the walls of the bronchi. The causes of wheezing include wheezing associated with lower respiratory tract infection, bronchiolitis, bronchial asthma, tropical eosinophilia, and Lufla syndrome. As you might remember, Lufla syndrome, we said there is pulmonary eosinophilia as a result of parasitic infection. The pulmonary phase of migration of the Ascaris larvae might cause wheezing. Inhalation of foreign bodies can also cause wheezing. Usually, it causes unilateral localized wheeze, which is sudden in onset. Here, the wheezing tends to be continuous and becomes worse with crying, during excitement, and with cold. Rare causes of wheezing include pressure from enlarged mediastinal nodes or from anomalous left pulmonary artery compressing the right main bronchus. Cystic fibrosis can also cause recurrent wheezing. Cystic fibrosis is a genetic condition. So in addition to the productive cough and malabsorption, it usually presents with recurrent wheezing. Usually some have history of meconium ileus in the neonatal period. And you might be asking, what's meconium ileus? It simply means there is obstruction of the small intestine, especially the ileum, because the meconium is thicker and stickier. And because of the meconium becoming thick and stickier, usually there is obstruction in the ileum. So patients presenting with cystic fibrosis have usually recurrent wheezing in addition to the other presentation of cystic fibrosis. The third abnormal respiratory sound is stridor. Stridor indicates upper respiratory obstruction and is usually accompanied by hoarseness, brassy cough, dyspnea, chest restriction, and restlessness, as in the case of croup. Stridor is frequent in infants, and this frequency is attributed to the small size of the larynx, loose subcutaneous connective tissue around the glottic region, and because of rigid cricoid cartilage encircling the subglottic zone. Stridor can be acute in nature or chronic. Acute stridor occurs due to acute upper airway obstruction occurring in the region of the glottis, which is produced by inflammation and edema. The obstruction may either be above the glottis or below the glottis. If it is supraglottic, it is as in the case of epiglottitis, or subglottic as in the case of infectious croup. Causes of chronic stridor include congenital laryngeal stridor, congenital laryngeal or tracheostenosis, laryngeal cyst or neoplasms, neurogenic stridor, extrinsic obstruction, and other miscellaneous causes. Miscellaneous causes include hydrocephalus and those patients with Down syndrome. Other causes include micropnathia, thalassoptosis, and macroglossia. Dyspnea is another common presentation in patients with respiratory disease. What's the difference between dyspnea and tachypnea? Tachypnea refers to abnormally rapid respiration, and in a more realistic definition as per the WHO, tachypnea is defined as increased respiratory rates in a specific age group. A child less than 2 months of age is considered to be tachypnic if the respiratory rate is more than 60. Between 2 to 12 months, if it is more than 50, the child is considered to be tachypnic. Between 12 months to 5 years, more than 40 breaths per minute is considered to be tachypnic. And if the child is older than 5 years, 20 breaths per minute, more than 20 breaths per minute is considered to be tachypnic. So, tachypnea is usually a sign, while dyspnea means difficulty in breathing. So dyspnea is a symptom usually patient present with, and it's accompanied by pain and hunger for air. The causes of dyspnea range from illnesses affecting the lungs, the heart, and the musculoskeletal system. Therefore, dyspnea is not specific to the respiratory system. Other systems like the cardiovascular system and the musculoskeletal system can be affected. Epistaxis or bleeding from the nose is rare in children below the age of 3 years. It may occur due to local or systemic causes. Local causes of epistaxis include trauma to the nose caused by nose picking, capillary malformations in the littlest area, foreign body, bleeding polyps of the septum, allergic rhinitis, and nasal diphtheria. Systemic causes of epistaxis include hypertension, blood dyscrasia, emphysema, and pertussis. What's blood dyscrasia? Blood dyscrasia is abnormal disorders of blood. It can usually be traced back to the Greek physician Galen, and it literally means bad mixture. Thanks for watching. In our next lecture, we will discuss investigations for respiratory illnesses.